Financial implications, the push from inpatient to outpatient care. I'm pleased to be joined with such a great panel with us this morning. Their great insight and expertise and personal experiences within their organizations. We'll be answering some questions that I'll ask, and we'll also have some time to get questions from all of you of the panel. My name is Richard Soohoo. I'm the CFO at Sutter Medical, Center-Sacramento. I've been with Sutter Health for 29 years in various financial roles throughout the organization. And much like each of our panel members here, we also are experiencing the trends of less inpatient volumes and more pushing to the outpatient. We'll spend the next 60 minutes, and then we'll also have 15 minutes of some Q&A, as I mentioned, and the panel here will be able to share their experiences and also the strategies and what they're seeing as going forward in the healthcare arena. So let's go ahead and get started, and let's get to know our panels this morning. Start with Tim.
Good morning. I'm Tim Maurice. I'm the Chief Financial Officer for UC Davis Health here in Sacramento. UC Davis Health is part of the University of California system. We have 5 healthcare campuses with 10 hospitals here in California. Here at UC Davis Health, we provide inpatient care to adults and children. We're a level 1 trauma center serving 33 counties throughout Northern California and the Central Valley. I've been here for 7 years. I'm the Chief Financial Officer of the School of Medicine, the School of Nursing, and the Medical Center. And our medical center is quite broad in terms of our outreach. We serve about 1 million clinic visits a year, about half of those in primary care and half in specialty care throughout the region. I've been a member of HFMA since 1976 and actively engaged in HFMA in Washington State, Michigan, and here in California for many years, so glad to be here again.
Good morning, my name is Iftikhar Hussain. I'm the Chief Financial Officer at El Camino Hospital. El Camino Hospital is a 2-hospital system in Mountain View. We have about $1 billion in revenues. It's really a very good community to be living in, and actually a very, very expensive place to live. Yeah, so I've been there about 3 years. The hospital's doing extremely well financially. Getting into the discussion, you kind of see that our volume actually has grown. Prior to El Camino, I worked at Sutter for about 20 years, and then before that at Dignity, and before that I worked for F2F and CPA firms, so that's my background. One thing I want to add though is, in addition to professional experience, I have been a patient in the hospital too, so I think it's important to bring that to you as well, as we talk about shifts in care, not just look at the financial side, but also the safety and the quality of care as we talk about the inpatient outpatient.
Good morning, I guess good afternoon now. My name is Kari Cornicelli, and I am the VP CFO at the Sharp Metropolitan Medical Campus in San Diego, California. I've been at that campus 4 years now, and I oversee Sharp Memorial Hospital, Sharp Mary Birch Hospital for Women and Newborns, Sharp Mesa Vista, and Sharp McDonald Centers. So we have 3 specialty hospitals and the acute care hospital. About a little over 1,000 beds, about 1.5 million in 1.5 billion in net revenue. We are part of Sharp Healthcare in San Diego, the largest healthcare provider, and we've grown market share for each of the last 19 years, so we're doing extremely well. We are very active in the capitated world. We've been doing capitation for about 35 years, so that brings a unique ability, I think, to compete in today's transforming industry. I've also been a member of HFMA, not as long as you have, a long time, since 1985, and have enjoyed working both at the local, regional, and the national levels. So it's a little bit about myself.
Thank you. Well, as you can see, we have a pretty esteemed panel here with us today. So Inpatient volume, we're going to start to experience a push-pull effect, I believe. As the population continues to grow, health status indicators decline, and the population with health insurance remains about the same in 2017 as it has in the past. Both the volume, inpatient and outpatient services, we expect to continue to grow, but I think the market trends are going to start to really have that growth kind of in check there. Moderating or mediating forces, we're going to include things like the care models that we're seeing out there. Examples, ACOs, bundled payments, chronic disease management, patient-centered medical homes. All these types of things can help curb that acute care utilization that we're seeing. Plus the use of incentive-based items, as well as technology and to improve efficiency, the use of hospitalists, case management, all of these types of things are in economic incentives to help bring down the inpatient stay to a less expensive setting on the outpatient side. So I think all of those combined together, we're going to start to see the inpatient volumes flat and then continue to decline. So why the trends? Why is pushed from outpatient or to outpatient from the inpatient? So we all know that the GDP plus 18% of the GDP in healthcare. CMS is pushing for less expensive services in healthcare as well. And so as a result, hospitals are seeing less inpatient admissions and inpatient days are on the decline as well. Just some of the key indicators that we see in the hospital settings. So let's go ahead and get started with our questions for our panelists. So let me start off for the panel. What trends are you or your organizations that you work with seeing with respect to inpatient, observation, and traditional outpatient volumes? And anyone can start with prior to that.
All right, so I'll jump in. So we're seeing, at El Camino Hospital, we're seeing pretty much flat volume. Inpatient volume has been fairly flat, and it's looking at inpatient surgeries, and then the outpatient business actually has grown. So we are not seeing a decline in the inpatient side, but a pickup on the outpatient side.
At my particular campus, it's a mixture. Obviously, if you go to the behavioral health side, we aren't seeing a decline in volume there, so continuous increase in volume. The biggest issue there is that patients are more acute, staying longer, so we're not able to get as many patients through the continuum as we have historically. So therefore, although cases are going down, the length of stay is high and the throughput's not what it needs to be. We're seeing a decline in births at our women's hospital, and I think that's being seen countywide across the state and in the country as well. If that trend changes, then perhaps that'll go back up, but right now it's a definite decline, and I think we're entering our third year of a decline there. And on the acute side, we continue to see growth on the inpatient side. Our market is growing with seniors, and of course, seniors use the hospital a lot more frequently than perhaps the younger generation, which is where we see the least amount of growth in our community. And I don't expect that to change, but what we are seeing is a transition from that inpatient setting to an observation bed. So they're still staying, 2 days, but it's as an outpatient, and that makes up about 20% of our total admissions now, which is quite a lot, especially when the reimbursement is so much less, and the cost is really no different. We continue to see pretty strong growth on the outpatient side as well in ER visits, and declining volumes on anything that can literally go off the campus and somewhere else.
At UC Davis, we've actually seen a significant increase in our inpatient census as well as outpatient census, largely due to the Medicaid expansion in California that's had a big impact in our marketplace. About a third of our inpatients are Medi-Cal. And so as we've seen that Medi-Cal expansion, it's put a real pressure on our inpatient facility. We have an average daily census of about 500 adults and 80 children in our hospital. It's a combined adult and children's hospital. And that's putting huge pressure on our capacity. We're running at about 90% plus every single day. And just imagine the stress that puts on the caregiver teams. despite the move towards reducing length of stay, there's only so much you can do to reduce length of stay. And so we haven't seen a significant drop in length of stay, but we've seen a significant increase in reduction in readmission rates. And I think just that move towards value-based care and pushing on reducing readmission rates, that's the only real factor that's reduced the admissions to our hospitals is readmissions. That's increasing our admission. Our emergency room visits increased dramatically in 2014 and 15 and now stabilized. But we now have over 80,000 ED visits per year. So pretty substantially impacted. Our outpatient activity in terms of outpatient surgeries are fairly stable. And our clinic visits are running, as I mentioned, about 1 million clinic visits, about half of those in primary care and half in specialty care.
So thank you for the answers, and just to drill a little bit further in that, you talked to Kari a little bit about some growth on the inpatient side, and Tim had also, and he referred to the managed Medi-Cal arena that driving some of that volume. Kari, in your areas, I don't know if it's the same or not, or if it's just growth within your market that you've seen. But with that being said, at some point you're going to start to see that the financial pressures put on to move it more of that care to an outpatient setting. So tell me a little bit more about what your organizations are doing to prepare for the drive to outpatient, and what does that mean for your organizations?
Well, for us, from an integrated network perspective, we already have a very strong medical group landscape. We have 3 affiliated medical groups, and all of them, one of them isn't growing as fast as the first one. Sharpie-Steely has had year-over-year growth. We didn't hit our budgeted growth this last year, but they still had really strong growth. And that's really where we're preparing, for the changing landscape, is through our ambulatory care models and through the physician practices, and we have had significant growth there. But we've also seen significant growth in our surgical volumes over the past few years on an outpatient basis. Again, the only place we're really not is like imaging, where that's being driven outside of the facility. We've had strong growth in the emergency room visits. We're at over 100,000, and that since we opened our new ER, we've caught up with our sister hospital, Grossmont, where I came from, where we had like 100,000 visits just a few years ago. We've literally caught up with them. So just continuing to lay the landscape as an organization to get patients tapped into a primary care home where their care can be managed, and we can keep them in the outpatient setting and really reserve inpatient for the truly acute ill.
So we haven't seen a decline in the business yet, but what I see coming that's kind of concerning is not a shift from inpatient hospital to outpatient hospital. It really is the shift from hospital setting completely to standalone surgery centers and imaging centers. And for that, though, I think well, let's talk about the plus side first. So the benefit on the outpatient setting is that the processes of throughput are really refined. You do a lot of cases. Most surgery centers can do 8 or 9 cases a day. In a hospital setting, we only do about 5 or 6 cases per day per room. So the throughput processes, the turnaround time, are a lot more efficient. The cases start on time and on time. So that's the plus side. The downside is that once you leave the hospital, the care team in a surgery center is not the same. So for most people, that's not an issue, but if in cases in which there's a respiratory distress, anything unexpected, you're really taking a risk in the outpatient setting because it's not really designed for that type of care. And so in that case, I think even though the cost is lower, you're giving up quality and safety when you move to the outpatient side. We are seeing the first shot across the bow was Anthem saying that they will not authorize imaging, patient imaging in a hospital setting. And so far they have not really executed on it. That policy was supposed to go into effect in January this year. And they started out with imaging, so then CT and MRI. We try to negotiate with them, see how we can retain that volume, and they're just being overly aggressive. And so it's unlikely we could reach agreement on rates at the rates that they're looking at. But you know, the imaging itself may not be as concerning, but if we start having invasive procedures, outpatient surgery centers moved into standalone centers, I think costs may come down, but it may come down at, you know, with a detriment to quality and safety.
We've been investing substantially in growing our ambulatory footprint across the region. We have over 16 care facilities in our clinical network that provide both primary and specialty care. Recently, in the last year, we've tripled our capacity here within 2 miles of this hotel with a large outpatient center, about 90,000 square feet of primary and specialty care here in Midtown. But we plan on making further investments in Folsom, Roseville, Davis, Elk Grove to continue to grow. We're also making substantial investments in our oral capacity. We do a lot of outpatient surgeries in our main hospital operating rooms, surgical suite. We intend to increase our ambulatory capacity so that we can move some of those outpatient cases to freestanding facilities under our name. But in the meantime, we're really dealing with capacity issues. We're facing day-to-day constraints both on the outpatient side and the inpatient side.
So Iftikhar, you mentioned that the Anthem on diagnostic imaging, that they had put out the memo that they were not going to approve inpatient services. And I know that they had kind of held off on that. Most of the hospitals have received that memo. But now they're starting to develop the guidelines around that. And obviously what we're seeing is that those guidelines are saying these are diagnostic imaging services that can be done based on these clinical guidelines, and we will not reimburse you if you don't have justification, and we will push them to the outpatient. So these are the type of trends that we're seeing, and it's just right around the corner that Anthem will enforce that. There's no doubt about it, because the cost element between the inpatient to the outpatient is so different. You mentioned surgery centers as well, Tim, and if you look at data that's available, we start to see now that surgery centers are on the rise as well. Outpatient ambulatory surgeries, especially what the panel has said here, we're seeing that movement. We're seeing things where more of joint replacements that are typically done inpatient are now being moved to an outpatient setting in the healthcare market. And again, it's the outpatient, the cost to provide that service is just so much less. So knowing that, what you're all experiencing, what are your organization, the financial trends that your organization has seen moving from some of these inpatient services to outpatient? As we know, the reimbursement is greater on the inpatient side. So as you move it to the outpatient, what are your organizations doing to, when they're starting to lose 20% of the reimbursement on a procedure, just because it went from inpatient to outpatient? What have you experienced, and what are strategies on that?
So on clarification on the financial side, so for Medicare, going from an inpatient to outpatient, the case that you mentioned, which is the knee replacements, is a hit because the DRG obviously is a lot more. And the criteria is that Medicare that you cannot do that, then it's an outpatient. The problem that arises is that the person doing the documentation is the physicians, and lots of time they're entirely focused on the procedure, and so there may be a very good reason to do it on an inpatient basis and schedule an inpatient, but getting the doctors to document requires more of their time, and there's often a pushback. So even though the care is being provided in the right setting on an inpatient basis, we would end up with a denial. On the outpatient, on the commercial side, we actually get financially we do better on the outpatient side. So on an inpatient basis, most hospital contracts are per diems, and if you have a short stay surgery, you actually are financially better off on an outpatient basis. But if commercial starts following this two-step process, of course, make it outpatient and then say, well, you can't do it in the hospital, that would really start to hurt, because that's a big, big piece of our margin in the outpatient surgeries.
And the likelihood of that moving, Iftikhar, especially if outpatient surgeries like that have clinical effectiveness, don't you think the commercial would pretty much trend what Medicare is pushing?
Yeah, so they, so I'm pretty cynical about the insurance company. So, so the people from insurance companies here.
Right. So, when I work with them on contracting and stuff, it seems that the decision-making process is really driven by keeping costs as low as possible at any cost. Because they have quarterly targets, they have budgets for loss ratios, which is the services that we provide. So their primary driver when they implement, even though the idea to be well thought of is to how to get the cost down. And they often are not worried about quality and medical necessity.
Well, we have an outpatient pavilion on our campus, and so we have the OR suites in the outpatient pavilion are as busy as our main house. And we are at capacity there as well. So we've been really focused on what kind of procedures can we now move out of there into another even lower level acuity to move the higher acuity from the main OR into the outpatient setting. So that's been a really strong focus. Are going to move that business. They've already been testing the market. We see hysterectomies, lap choles, angioplasty, gallbladders, all of that are now being done on the outpatient setting. And it's yielded significant savings, both to the health plans and it's yielded significant savings to the consumer. And when you really step back and look at the consumers that are purchasing these high deductible policies, they're going to look for the lowest cost option, and we have to find a way to be able to compete with that. I know for our own organization, our biggest challenge is we pay staff the same across all settings. And so even though we have extremely good throughput on the ORs and turnaround times, et cetera, the cost of staffing an OR is really pretty much the same as staffing the main OR. So it's really trying to find ways to decrease the cost and increase throughput, because we are definitely going to see a continued shift. The payers have already proven that they can save money and they're going to demand more. And with site neutral payments for Medicare, it's going the same direction as well.
I'd say we've been taking a bit of a different approach, and that is we do the right thing and we let the finances take care of themselves. So it's not that we've been focusing on where the line is as much as we've been focusing on how we can improve health through delivering coordinated care. So we're part of the public hospital waiver program here in California, where we have 5 years of DSRIP, and now we're in year 3 of the 5-year PRIME program. And in our PRIME initiatives, we are focusing on a number of quality initiatives that are really ambulatory based to look at how we can do a better job of coordinating care, how we can identify the patients in need, and identify how the patients can engage in their own health. And that's required a lot more staffing and new positions that we've never had before in terms of care navigators, care coordinators. We have much higher use of nurse practitioners and physician assistants. And that's only added to our costs, but at the same time, I really feel it's the right thing to do. So our technology and our physician ordering patterns will guide where care is given, more so than where they get an authorization. But we have to find a way to bring our costs down wherever we can, and not necessarily tie the cost to where the reimbursement is. So we do a lot of robbing Peter to pay Paul. And in doing so, I think we're making the right investment in ambulatory care and providing the transitions of care, the care coordination. All of our community clinics are patient-centered medical home certified, and that's really where care is going to be provided in the future. We also have invested in our engagement with our patient through our electronic record. We're on an Epic system, and all of our patients have access to MyChart. We're going to expand that engagement so that when they check into a clinic, they'll be handed a tablet so they can provide more information about their medical condition, about their health history, that will help us even more care for them and personalize their care.
Thank you. So has your organization seen increases in denials due to the shift in classification of patients, inpatient, outpatient? Have any of your organizations seen that on the rise?
We have one payer in San Diego that has gone through has increased denials, but really only at one of our hospitals where the volumes, or two of our hospitals where the volume's the biggest. We haven't seen it as much on our campus because we don't have that payer. I think we've done a real good job educating physicians on the documentation and really trying to follow the rules pretty closely in that to avoid the denials. So we've done okay so far.
So so the Medicare change, the knee replacement to the outpatient, we are managing that process. So we haven't really seen a lot of denials yet, but in working with the physicians to have the documentation justifying the inpatient stay, it has been difficult. It's not, we have independent physicians, we don't really have a lot of employed physicians. So it really requires negotiation on the documentation. The physicians see that actually as number one, more work with them. Number two, the patient copay for Medicare patients is higher in the outpatient setting versus the inpatient setting. And there's also additional services we transfer to SNF. There's better benefits for the patient if they're on the inpatient setting. So the doctors I find are conflicted. They would rather have the procedure on an inpatient, but we may end up getting denied.
For our total joints, we have on our orthopedic service line, we have a total joint class, and so we are meeting with every patient before surgery, talking about what's to be expected during their care process, and talk about their insurance coverage, etc. So we're trying to align, starting with the patient, all the way through with the physicians as well. But you know, physician documentation is always a challenge. There's no doubt about it.
We have seen an increase in our denial rate from our major commercial payers, particularly additional denials where they're denying for medical necessity, and we're going back and providing further information, and every time we do, we get the denial turned over. So it's really increased the burden of care and the administrative costs of care. It hasn't added much value, to be honest. So what we're working on now is to really improve our clinical documentation up front and get past, avoid that initial denial. But frankly, I'm just seeing more and more requests for medical records that really don't drive decision making, they just delay the payment. And it increased our administrative burden despite the fact that we're fully electronic in our medical record.
Have you considered giving access to the payers to your medical record? We do that for patients as long as we have our business agreement with them, but we're giving direct access, and that's really slowed down our front-end denials. As soon as we know we have a denial, we're trying to get it off before the patient ever even leaves the hospital. So that's one thing to consider. It took about 2 years to get the infrastructure set up to give them access, but it seems like it's really made a difference for us.
We haven't reached that point yet where we're providing indirect access, but I do think that that's somewhere down the road. If we can really beef up our cybersecurity to make sure that that's a secure connection.
So along that theme of technology and innovation, Tim, you mentioned some medical home model centers that you have. Kari, you mentioned about giving the payers access to the health record. What other things are your organizations doing from a technology innovation standpoint to help with those shifts and those changes that we're seeing coming upon us?
One of our biggest challenges has been behavioral health patients and being in the ER and being able to do a timely assessment while they're in the ER and then move them into the right setting rather than have them spend 6 to 3 to 4 days, 6 hours to 3 to 4 days in the ER. So we implemented telehealth, and we're doing all of our behavioral health screenings at a couple of our hospitals through telehealth, and that has really helped us expedite the transition of care into lower levels. We're using that as well in one of our smaller facilities for neurology and strokes, which has been very helpful. And I think telehealth is going to really transform our industry again. 2 years ago, we were at like 250,000 nationwide on telehealth visits, and it's supposed to exceed like 3 million this year. So it's really turned out to be an effective way to provide care at a lower cost.
So we have Epic. I think most hospitals in the Bay Area have Epic system of care. It really helps in the ED when patients coming in. You can actually find getting information about their background and history really helps. And then we have, like Kari said, we have telehealth psychiatry in our ER. It doesn't. It's better than. There's some challenges with it. We struggle with the turnaround time because these patients come in unevenly, but we have pretty serious suicide risk, and so you can kind of imagine a delayed response is very problematic. So we have been working with one vendor for telehealth services now. We are contemplating switching to a different vendor, it's kind of so the results are kind of mixed on telehealth, mainly around not that technology is an issue, really around the vendor responsiveness and the time to response.
Well, we invested in telehealth nearly 10 years ago. In that we were one of the early innovators in telehealth in California, and we're a developing partner in developing the California Telehealth Network that brought telehealth to rural communities throughout California. That's something we're very proud of. And in doing so, we started out doing telehealth primarily on an outpatient side for specialty access, but where we really made the investment recently is in providing inpatient telehealth services to other community hospitals so that patients can be treated in their home community and not have to come to the academic hub. So we provide teleneurology, telepediatrics, tele-ICU to community hospitals around Northern California, and that's been a very successful relationship that we built with those community hospitals to keep patients in their home base. So it's not the drive to outpatient care, but it clearly leads to providing inpatient care at the setting where it's better for the patient, it's at a lower cost, and it's better for the community.
So tell me a little bit about your organizations, and I know the CMS applications for bundled care was out there recently. So what are your organizations doing with that? Participating, not participating? Any strategies that you can share with what you think where you're headed?
I'll start with that. We really haven't participated in any large bundle payments programs yet. We just haven't seen the risk adjusters that would adjust bundle payments for the types of patients that we see that are much higher risk with comorbidities, and that's where you can really get hurt with bundle payment programs. But we have developed an ACO. Our faculty serves our medical centers, so we have a very small outside independent physician network, but we see that growing over time. And we do have an ACO model that we developed, but we're just starting in the early stages of Medicare Shared Savings Plan, first tier type programs for shared savings.
So we did the BIPSI program for 4Ks for DRGs, and the track that we were on is we focused on cost 90 days post-discharge. And our strategy really was to reduce the use of skilled nursing, and we did not succeed actually. So the skilled nursing facilities have a business model based on a certain type of care for a certain length of stay, and we encounter a lot of difficulty in changing that model. So for instance, what it requires is that I think typical skilled stay is about 30 days, that they would have to go to about a 15-day stay. And the shorter the stay in the skilled nursing, the more they have to staff up because most of their work is done when the patient is admitted. And they need the 30 days to kind of even out the services. And for them to kind of discharge the patient 15 days, they just really push back. So we have kind did that as an experiment. It didn't work out good.
We have chosen so far not to do any bundled payments. We just got out of the next gen ACO model, and that's the second time we've exited Medicare or CMS's programs with ACOs financially. We have not done well, and what's most interesting is being in a capitated environment and at risk with our physicians, with our health plan and the hospitals. We've done very well for 35 plus years, but can't seem to figure it out with the federal government and their rules, and we can go on that one. But anyway, we are in commercial ACOs. We have a couple of commercial ACOs, and we've been in Medicare Advantage plans for years and do very well managing costs and managing quality, but the innovation programs have not panned out for us.
So you have mentioned, the three of you, that your inpatient volumes have been pretty robust, and referred to the managed Medi-Cal arena there. So as we all know that as CFOs, you're not going to sustain by having that inpatient volume. So that trend of moving that out of your hospital in the outpatient care setting, what's that look like? What's your time horizon? What strategies do you all are implementing to put in place to reduce that length of stay, those inpatient episodes that you have?
Well, nothing happens fast in California if you have to build facilities. And I think that's the big issue that we have when we do our strategic planning, is that we have to add such a long tail to get a building designed, approved, permitted, and constructed. And the cost per square foot is just astronomical, even for outpatient facilities if you're going to have them accredited. So I think that nothing is going to happen fast in our marketplace in terms of building facilities, but I do believe that over the next 10 years you're going to see a substantial shift. One thing that most people don't realize is that the 2030 seismic standards are much more stringent than the 2020 standards, and if we saw a lot of hospital construction preparing for 2020, we're going to see a lot more preparing for 2030. And so we're going to be making substantial investments in inpatient facilities to replace beds that can no longer be in service as of the 2030 standard. And yet the cost per bed is just blowing my mind. I don't know, maybe I'm too old to deal with these big numbers, but these are very big numbers, and they're very big numbers relative to other states. So I would really like to see us do something from a policy standpoint to identify what the driver is to the high cost of construction in California so that we can provide the care where it's needed and reduce those timelines for building new facilities.
So do you think it's a burden on your overhead cost structure, and you're saying that you'd like to reallocate those funds to more outpatient type care or programs to help with the reduction of inpatient?
I'd like to, but I can't.
Okay.
So what I'm faced with is I've got a substantial investment that needs to be made to replace inpatient beds just to maintain our current bed capacity, and I need to expand my outpatient capacity. So we're doing master plans across our region for outpatient care, on our campus for ambulatory, and on our campus for inpatient, and it's adding up to huge numbers. So what I've been doing is trying to ignore the numbers for a while and let the planning take hold, because if I look at the numbers, I just run away scared. And you can't do that if you're really going to effectively plan. So we've been very careful not to pay too much attention to the cost of construction because it's so daunting, but more importantly, do effective planning, because once you put a shovel in the ground, it's pretty hard to turn back. And before we do that construction, we're really planning about where to make our investments, but I absolutely see it being in both fronts. We have to make investments in inpatient facilities and in ambulatory.
I think, well, I'm hopeful that CHA is working on the 2030 standards, and hopefully we'll be able to make some headway with legislators on lessening the burden. It's so significant, it will have a huge impact. And when you pair that with the cost of expansion to our state, both of those two factors are literally going to break our state financially. We can't continue on the path we have. There was a recent article published in the UT in San Diego,
and it listed the operating margins for 2016, so this is 2 years post-expansion. And every entity that was listed, operating margin, pretty much had a 50% reduction, which is significant. So we're seeing a lot of money come out of healthcare, and then to layer on the burdensome regulations and the seismic regulations especially, you know, it cannot continue on the path that it's on right now. So we'll hopefully see some relief, but I think it's going to take a few years, and we're going to see the union activity really push back on that relief, because who benefits from construction unions? So we've got a long road ahead of us, but the battle is being played out and planned around by CAHL.
So let me push back a little bit to our panel here. So I firsthand know the cost of construction. It's nothing new to me, but when you think about that, is the government telling us you don't need to build those big facilities, you don't need more inpatient beds? When you look across the country, inpatient days are actually down and admissions are down. So is it unique to California? Is it unique to our general market here? Or is it that they're telling us don't build inpatient, it's too expensive, and let's push more to the outpatient? Your take on that?
It's interesting, in my opinion, on the commercial side, we've done really well managing the patients and keeping them through our programs in an ambulatory setting, through the primary care, specialist care, all of the different models that we have. Medi-Cal patients don't have the same kind of models. The funds are significantly less, and even though you put them into Medi-Cal homes, they tend not to be compliant patients. There's a high cost of that, hitting your emergency room, etc. I don't know where it goes, but I do think California is a little bit different in that we had probably the highest amount of increase in the expansion across the country. Actually, I don't know the stats on that, so don't quote me, but it feels like the highest when I talk to colleagues around the country. I think we've definitely seen a substantial increase in that population of patients. Maybe you guys have better data on that, but that's what we're seeing.
So I think on the construction issue, I think you're giving the state way too much credit here. Inpatient, to build a hospital, so the seismic requirements you mentioned, are not to reduce hospital beds. The seismic requirements are a regular replacement function that to meet certain standards, I think like 72 hours, you need to be able to operate for 72 hours after a dramatic earthquake, which means that you have a place to store the sewer, you have fresh water. So those are the kind of things that you can't do with a retrofit in place. You really have to tear down and rebuild. So having said that, the regulatory process around construction, we at Mills, we rebuilt the hospital. The hospital construction took 4 years. The MOB, which is right connected to the hospital, took 6 months to build. And you can kind of see the scale that it has on cost. So the cost of building a hospital is about $3.5 to $4 million per bed. And even the high, so you got a good deal. No, it's 2009. So the regulatory burden on the construction side it does really translate into very, very high costs on the inpatient. And then you combine that, with the staffing ratio and other regulation in the state, it's really not conducive for efficient operations. All that cost has to be recovered. And making sure that the setting is right and the care is being provided in the right setting is perfectly a good point, and we all aim for that. But when you spend, $4 million a bed, it's going to translate into higher costs for everyone's healthcare.
I think if you really look at the market, I wouldn't say that Northern California is overbedded. And especially if you look at the market and say that you have to meet the 2030 standards, the number of beds that would have to be replaced just to maintain the current admission ratio for the population is going to create a significant demand for inpatient care that outstrips the supply of inpatient beds. Maybe not so much in Southern California, but if you take into effect the age of the facilities in Southern California, you're going to see a significant decline in bed supply in Southern California if that 2030 standard stands. So you can say all you want about moving patients from inpatient to outpatient, but you're never going to eliminate hospitals. You're always going to have patients that need to be admitted. The average length of stay in California is not long. I don't know how much further you can drive it down. What you can really do is reduce readmission rates, reduce those 1 and 2 day stays, and squeeze as much as you can out of the beds you have. And that's what we're already doing in California because the cost of operation is so high.
Yeah, so my intention, my comments were not to say that we don't need hospitals or are we underbedded in a city, but it's really driving the services that are offered and the expense that go with it. And we know how expensive healthcare is. So with that being said, the strategies behind this is really what I'm referring to, is what are healthcare organizations doing when you think about a population, and when I think about what our government reimburses for, basically within the 4 walls of a hospital, they're reimbursing for acute care services. And we all know within our acute care services, we offer way more than that, and we're actually not reimbursed for that. So that is my question to you as panelists, is what are your organizations doing to move that volume to an outpatient setting? Because we do so much now, nurse navigators, those types of things in there. Tim, you and your care coordination executive earlier were speaking with me about that care coordination, complex case review. How do you move those patients along? And it's not so much that the number of beds and how to reduce them, but the readmissions. How do we keep people out of the hospital? How do we have wellness programs? How do we partner with our medical groups to create a healthy community? Those types of things. So what type of strategies, things that your organizations are doing?
You know, one thing that has worked well is, the expansion of ACA. I think Tim mentioned the ER admits really went up, or the ER patient presenting with the ER really increased. And what we found is that people who are newly insured, Medi-Cal patients who are newly insured, had difficulty with access prior, with the expansion, so they had coverage, but they had no doctors. And so they started using the emergency room as the primary care. And that's really what the bump was in the ER admissions. And so, or in the ER visits. So, so one thing we were able to do is to have a partnership with a federally funded clinic where we subsidize them so they could expand their capacity and hire more doctors so that people could get access to a much lower cost setting and actually get better service with short wait times than say use ER for minor illness, which is extremely inefficient.
Yeah, we have partnerships with all of the local community clinics around each of our facilities. They don't have specialist care, so when they need to come to the hospital, we're still footing the bill for specialist care, which is challenging. But again, it comes back to that managed population. That's how we are trying to decrease costs. Take every patient that we can get alignment and put care coordination around them. We have like 6 outpatient programs for the medically complex patient, really trying to work with them through telemedicine and through devices and primary care access, making sure that our patients stay healthy and stay out of the hospital. That's really where the growth strategy is. We have been moving services out of the hospital and, outpatient infusion, building an outpatient infusion center, outpatient cancer center, and our outpatient pavilion that has surgery. All of those strategies we've moved out. We're still at capacity. So we continue to grow in San Diego County, which is a good thing for the organization, but I think we're always going to be challenged, and we need to continue to look at how we can reduce costs on the inpatient side so that we can take less revenue on the outpatient side. It's a hard equation to balance. The cost of providing care on an outpatient basis in the 4 walls of the hospital is just as high as on the inpatient side. So you've got to find ways to reduce costs and have an aggressive cost containment strategy. We've had a cost containment strategy for the last year and then this year of 23 to 25 million this last year and the same amount next year, and I'm sure we'll have the same going forward. revenues are coming down, so you've got to be able to balance that equation. It's not necessarily going to be by just moving things out of hospital, though.
Yeah, we've been focusing across the University of California to leverage scale for value across the 5 campuses, and in doing so, we're really looking at economies of scale across the state through our 10 locations. So our focus initially has been on revenue cycle and IT, moving into supply chain management and now pharmaceuticals. So we're just diving down deep into labor management, productivity management, overtime management across the board. We're diving deep into supply chain procurement to look at better partnerships with vendors around the supply chain and better logistics management of our supply chain. I've spent a lot of time on pharmaceuticals lately on a pharmaceutical task force with UC, which is daunting. When you look at the pharmaceutical marketplace and the introduction of new pharmaceutical companies that are buying out generics and then jacking up the price and creating shortages, it's really criminal. I have to use that word, it's criminal. And we have to do something about it as an industry, and I believe we are. And when I heard that Intermountain is working on a partnership with other health systems across the country to create their own pharmaceutical manufacturing company as a nonprofit, that tells you something. That something's broken in this industry and we need to do something to reduce costs. And if we can't wait for the government to fix it, we're going to have to fix it ourselves. So that's where we're really tackling costs, is across the 5 campuses, across all avenues of cost management, not just inpatient versus outpatient, but getting down back to the basics of how do you manage productivity, how do you manage overtime, how do you manage your supply chain, and squeezing nickels everywhere we can. I think that's really going to be our future. We're going to have to drive $100 million of cost out every year for the next 5 years.
Big task in front of you all, obviously. So let me ask the question of the panelists again. Tim, you mentioned about 85,000 emergency room visits. I know at Sutter Medical Center, we had topped off over about 105, 110,000 emergency room visits. And then last year, we actually saw a decline a little bit and went to about 102,000. And this year, for the first 3 months, we're actually back up again on trend, even surpassed what we had done in previous years. A little bit of a concern, obviously, looking at that. We had talked earlier about patient enters into the emergency room, primary diagnosis, belly ache, but the secondary diagnosis with that, psychiatric diagnosis. So what's happening? I know we all share these issues amongst ourselves here in our facilities. What are strategies? What do we do about that? Give me some information I can take back to my facility to help fix it. But in all seriousness, what are those things that are kind of innovative type things? We talk about building hospital beds, but we don't see psychiatric beds being built in our state. Those are challenges that are very much at the forefront and really can reduce the number of inpatient stays. Thoughts, comments?
So we're building, Camino, we're building a brand new replacement hospital for our psychiatric and expanding capacity. And that was based on community need, not financial returns. So it's a $96 million facility with 36 inpatient beds as well as outpatient programs. And so it's well received by the community, and it will serve the community well. I think the key really is to find the right setting for the right care. I think that's really critical. There's a need for inpatient psych beds, and as nonprofits, it's our really goal to meet that need. I think patients providing more access to access points for patients to prevent or visits to the ED is really beneficial. So I think we're looking at collaborations with urgent care sites where patients, number one, benefits them because of faster turnaround time, and number two, is a lot more efficient, lower cost setting than coming into the ED. So that I think is good. That's just a description.
In San Diego, I think a couple of the issues that we really face are lack of skilled beds, so that when a patient is ready to leave the acute care setting, from psychiatric into skilled nursing. There's just not enough beds to take those, or residential care units. We don't have either of those. So what we've seen over the last 10 years is closure of all of the facilities because the payment structure isn't there to support taking care of the patients. We've seen a significant increase in the homeless and that population, and really how do you care for them and provide the infrastructure around them, as opposed to being in the hospital. Once you get them into your hospital or even into an acute care facility, it's really hard to move them to the next level of care. And we just completed a couple studies at our facility, and is it cheaper just to keep them in the hospital or to wait for a skilled nursing facility, or should we even go out and contract for beds within a skilled nursing facility? And right now it still is less expensive to keep them on an admin day in your facility, but then that clogs you up of being able to provide services to other patients who need to get in that are waiting in your ERs. It comes down simply to not enough facilities at a lower level of care to move patients into, and there's not enough funding, and there is no parity in behavioral health reimbursement. Even when we say that there is no parity. Hopefully we'll see some of that change over the next couple of years, but that's the challenge that we're facing. We just remodeled our child and adolescent unit, and we had 7 patients, so we decreased the size of the unit, had them in a temporary location for the past 9 months, remodeled and opened, and on the day we opened and moved the 7 patients that we had in-house back, our unit was full by 10 a.m. That is the need out there that is not being met in the community.
Well, I think we're very fortunate here in Sacramento to have the partnerships that we have. And so we've been working closely with Sutter and Dignity and the county to really rebuild the county mental health program. And that's the only way, in my opinion, that we're going to solve this crisis. Fortunately, we have a fantastic psychiatry department at the university, and our faculty have just been phenomenal in identifying innovative ways to care for psychiatric patients and provide behavioral health services. They do so under contract with the county and the state to provide services at county and state facilities. And I don't know where we'd be without them. They're just phenomenal. So I do believe that we understand the problem. The problem is you can't treat behavioral health in the emergency room. It's the wrong setting. It's not safe. It's not conducive to the patient's needs. There have to be crisis intervention units in the community available to the patients to treat their mental health. And mental health is an illness and needs to be treated as a mental condition, and it's not being funded so. But I think we're doing innovative things today. We're working in partnership with the counties, and I think that's the only way that we're going to solve this problem over time.
Yeah, the mental health issue is very real in the emergency rooms, and it's not uncommon for the Center-Sacramento to have 12 psychiatric patients with sitter care, one-to-one observation out there, with really no place to discharge them to. It is a real struggle. And when you think about it, mental health is health care, and yet it is so underfunded and desperately needed in the communities and the state of California and local here as well. So let me ask each of you a last closing question. What keeps you up at night regarding the shift from inpatient to outpatient? What are your concerns? Because we know that it's moving that way. We see the stats throughout the country. We see it here in California as well. What is keeping you up about that transition? And it's going to come fairly fast, as we know.
I think one thing that's kept me up at night, literally for the last year, is my wife went through major surgery and I was her caregiver. And I spent a month home caring for her surgery, and when she was discharged after 5 days in the hospital, we had a dozen medications and a catheter for me to care for. And we didn't have that home health nurse scheduled that first day, and I was scared to death. But we got through it, and during that first month, we both learned how to manage her medications. I took 2 years of Latin, and I still couldn't understand these medications and couldn't help wean her off of her medications. We understand today the risks of not managing medications with the opioid crisis, and yet I can tell you as a caregiver just how difficult it is to wean a patient off of opioids after major surgery. It's hard for the patient, it's hard for the caregiver, it's hard for the team, but thank goodness I had not only the surgeon, but I had nurse practitioners, I had a home health nurse, I had a therapist come to our home, and I knew how to navigate the system to get those resources. And now, a year later, we are celebrating her 1-year anniversary from her surgery, and we're going on vacation in 2 weeks. It's going to be our first trip to Europe for both of us. So we are so thankful for the care that we've received, but this is modern medicine today. Modern medicine takes a team, and it needs home health services, not just outpatient services, but home health services. Patients need to be educated, their caregivers need to be educated. I just heard this morning, our School of Nursing is working with private foundations to develop a caregiver model for caregiver education. What a need in this community for us to teach caregivers on how to provide care, because they are part of our workforce. They take time from their work to care for their loved ones, and yet how much education and support do we give them? That to me is where the investment needs to be.
I'm glad to hear it's a great outcome, Tim, but I had one question. How did your wife fill out her patient satisfaction ACAP score? Communication and controlling pain. How did that work out for you? I see you're back to work now, so you must have got fired at home. So.
I told her that my bonus depends on her HCAP score. So 5 stars all the way.
Iftikhar.
So, I think there's a lot of, our healthcare system is not the best in the world. It's very expensive. Not everybody has coverage. But I think one of the things we do well is that if you find the right doctor, if you find the right hospital, you get outstanding care, you get better care than anywhere else in the world. So we want to make sure that as we transition and become more efficient, we don't lose the best of what we have. And I guess what I said earlier though is if people just think, well, no, I think you can deliver babies at home, you can do surgery centers and not, use hospital settings or some outpatient surgeries and complex procedures, I think we would take a step backwards. So, I think what worries me is this slide, the slippery slope that's out there, that first of all, the patient doesn't need to be inpatient. You switch to an outpatient status, possibly compromising care, and then you say, well, you don't need to be in a hospital, that you can be in a surgery center or a standalone center where the regulation, the safety rules are not at the same level. I'm not talking about ones operated by hospitals like you see in Sharp. I'm talking about standalone centers that are overly focused on cost and compromise care. You have respiratory distress, you have bleeding, they call 911, so then they take you to the hospital. So we've got to make sure that we don't move care to a lower level of care without a thought to safety and quality.
So at Sharp, our focus really is on continuing to grow and build on our ambulatory footprint with our 3 medical groups and working more in that we've actually started a few more foundations around specialty care too, to ensure that we are able to provide the specialty care to the community when they do hit our hospital. So those strategies will stay in place, continue to grow our capitated lives. But behind all of that and the continual shift in expansion and a lower reimbursement, what keeps me up at night most is finding ways to stay financially solvent. My hospital system that I work for, the 4 hospitals that I work at, are really almost entirely the system bottom line except for our health plan. And so it's really incumbent upon us to look for every opportunity that we can to reduce costs, and we are on an active high reliability journey to reduce errors and to improve the quality of care. I do think that there's a significant financial gain to be had by providing care the right time, the right place, the first time around, and to do it right the first time. So that's our focus, and what keeps me at night is really maintaining that bottom line and helping our teams find a way to do exactly what you talked about, managing productivity, managing premium time, decreasing costs in the supply chain, pharmaceuticals, etc. I guess the good news is for financial leaders, there's job security in all of this because we are really important in the equation of providing high quality care to the community that we serve. So.
Yeah, great, and I appreciate that because I do know firsthand that it is a daunting task in front of us. You know, my worries are much like yours, Kari, about continuing to make sure that the facility is solvent and can carry out the things that the community needs and the services. And I struggle with governmental leaders understanding health systems providing services, but there are also social services, and I know many of you have probably seen the graphs that are out there showing the United States as the highest healthcare spend per capita versus other countries. But we tend to blend the health services and social services, and that burden, a lot of that burden is put on the health systems, and it really doesn't belong in that arena. So trying to tease those two out is a difficult challenge, and I think when you were to pull that out, our actual hospital acute care spend per capita is very equivalent to other countries, but it's just masked in that is not actually graphed in the same format. What I'd like to do is thank our panelists for their time and their expertise and insights and sharing with all of us, but at this time open it up to questions that you may have of the panelists. And we have 2 microphones.
We know that there's a cost shift between the government programs to the commercial programs. As the population ages and if there's a shift from inpatient to outpatient, how do you think that cost shift affects the commercial population? Are we going to see increased premiums and that sort?
Well, premiums are already going up on the private side, so I think that is going to continue. You're going to see more plans that are, high deductible plans, and more burden shift to the commercial payer, and especially to the actual consumer themselves. So you're going to see a definite shift in all of the cost of healthcare being borne directly by whoever's accessing care. Wouldn't you guys agree? I mean, the consumer movement is going to hit us very hard. And we're seeing such a significant increase. I'd say 20%, it's between 14 and 20% in any one given month of how many patients are aging out of high-paying health commercial plans and into Medicare Advantage plans. That's how quickly the shift has begun. And it's a significant change in your bottom line for providing basically, again, the same level of services to each population, but you're getting paid a lot less. It's going to be a challenge.
So I think that the shift will exacerbate the problem, but we've already kind of hit the limit of how much we can cost shift. With the high deductible plans and share of costs, and the employees are starting to face the cost shift. And I think it's really hard from the payer's point of view to kind of justify, well, they need to pay, I need to tax you for the Medicare patients where the government's not paying us the full cost. So we do. So that actually is a dark cloud over the industry. I think our business model rely on cost shifting, but that would plateau out.
Well, I agree that the cost shift to the commercial plans have really reached their saturation point. Yet at the same time, the marketplace is becoming so disrupted through the dismantling of the Affordable Care Act, and as a result, I'm not going to get sick health plan is the plan of choice for a lot of young people that really is dangerous. It's dangerous for them and it's dangerous for society. So, in my opinion, we have to find a way out of this towards universal coverage of some sort for our communities so that the cost can be shared across society and not be borne by a small subset. And that's what happens today. That's what happened 40 years ago. It's just becoming more pronounced today and it's reaching a saturation point.
Ryan, I think you have a question.
So on the behavioral health subject, is there any models that you've seen out there that look to be successful?
I have not.
So I think so I think on the healthcare side, we do a disservice for the behavioral health side because I think the reimbursement rates are extremely low.
and so the care that's provided is compromised. I think the hope is, at least for young people, is to intensive outpatient programs where it's not just seeing a counselor once a week, but having a classroom type setting with an intense 4 or 5 hours of therapy over a course of time. Really, we found that to be effective. And that's actually pretty efficient too, because the outpatient process is a lot better. But on the behavioral health side, the inpatient side of behavioral health, not only does government payers not pay well, but commercial payers pay really poorly as well, because it's often outsourced out to a different division, and there are no advocates for those patients who are affected, and so it's the service is suffering. Yeah.
One thing we've been piloting is we've had our psychiatrist faculty train our primary care physicians in providing basic behavioral health in the primary care setting, and I think that's been effective. It hasn't, though, stemmed the tide of the emergency cases, because these typically are patients that are not seen by our primary care physicians. So we really, the innovative models that we see are the crisis intervention models, where there's available crisis intervention services in the community, and we're working with the county to develop PUFs. I don't know what a PUF stands for, but I know it's a 14-bed inpatient psychiatric facility in the communities. There needs to be more of those in the communities to provide longer-term care.
I know there's a model in New York, and I think it's a state program, and they use a lot of technology and monitoring of the patients on the outpatient side and try to head off them becoming an acute care patient. I can't remember the name of the program, but I sat through a very interesting presentation by a psychiatrist that shared, all of the work that they're doing, and it seemed like it was making a big difference there. I'd have to look up the name. I can't remember what it was.
Okay, thanks. Question?
My name is Shirley Rowe, and I'm the Vice President for Behavioral Health with the Hospital Association. So
And you do an amazing job, Shirley.
Thank you. First, let me thank you guys for talking about behavioral health. And then just remind people, if you want to know about some models that are working in the emergency departments, the closing session tomorrow has got a great panel on behavioral health. So don't leave.
There's your plug.
Any other questions for the panel?
How are you handling the cost shift with the rising rate of provider retirements?
Well, I don't know how I got this appointment, but I'm on a committee to deal with the retiree health benefit for University of California retirees. The retiree health liability for the university is $16 billion on our books today. Talk about daunting task. When you look at retiree health, though, and you look at the cost of retiree health, a large portion of that, the real cost to the retiree, is pharmaceuticals. And so if we can tackle pharmaceutical costs and tackle the abuse of pharmaceuticals in terms of ordering patterns and how pharmaceuticals are used, we can really bend the cost curve in terms of out-of-pocket retiree costs, at least the way benefits are structured for Medicare today. But I'm thankful that I'm part of the university that has a retiree health program, but I don't know how long it's going to last, or if it's going to last through my retirement, because it's such a daunting cost.
So yeah, getting primary care physicians is getting more and more difficult, and there's in the VA the Plex war going on, the bidding war going on. So that is, I completely see what you're saying, that's making the cost even worse. It is unfortunate, but it is actually more efficient. You want to provide care at the lowest cost setting, and without a primary care network and good access points, you kind of go off on the wrong foot. So yeah, so that's the problem we're facing. I don't really have a good answer.
Any last questions? Okay, well, I want to thank you.
Thank you so much.